It's the weekend. Be good to yourself. It's Katz's Corner with Dr. Aaron Katz and Dr. Philippa Cheetham, where you can get simple, straightforward answers to your questions about health, from diet and supplements to lifestyle changes. To reach Dr. Katz and Dr. Cheetham, call 800-848-WABC. Now, live on 77 WABC, the chairman of urology at Winthrop University Hospital in New York, with co-host Philippa Cheetham, attending in urology at Winthrop University Hospital. Here is Dr. Aaron Katz.
Good morning, everyone, and welcome again to another live round of Katz's Corner here on WABC Radio in New York. I'm your host, Dr. Aaron Katz, and we are live on this wonderful, well, it's kind of rainy, isn't it, Philippa, but a wonderful Mother's Day weekend. And good morning, everyone, and happy Mother's Day to all of our listeners out there. I want to wish my own mom a very happy and wonderful Mother's Day. I love you, Mom. Good morning, Philippa. How are you?
Good morning. Happy Mother's Day too. Although Mother's Day in the UK is earlier in the year, so happy American Mother's Day, Mom.
Oh, it's not It's not the Mother's Day in the UK?
No, it's the Mother's Day in the UK is in March, so a few weeks difference between the two.
Yeah, why we should change that? Make it a worldwide Mother's Day. You know, I don't know. But
Father's Day's the same.
Is it really?
It is. Father's Day is June 15th, all over the world, I believe, anyway.
Oh, well, that's good. And now that you brought up Father's Day, I want to remind everyone that on Father's Day weekend, that's the Saturday before, on June 15th, right, Philippa, we're running our annual Men's Health Seminar. We already have, well, it's almost filled up, but you can still register. We would love to see you all out there. We have a wonderful day planned at the Garden City Hotel. It's menshealthseminar.com, menshealthseminar.com to register. We hope to see you all there on what we believe will be a fantastic day for men's health, and you'll learn a lot, and you'll also be able to meet others with similar issues and see old friends and make new ones. So menshealthseminar.com. Dr. Philippa Cheetham and I were at the AUA last weekend in San Diego for the national conference, where over 10,000 urologists came. And we learned a lot, and we're going to talk about all we learned today because there are a lot of new and exciting developments. Some that I think that we're both some we're a little unhappy about, especially the new AUA guidelines for screening of prostate cancer, where the AUA announced that screening should start now. At what age, Philippa? What did they? What are the new recommendations for PSA screening? Because it has changed, and it's continuously changing from year to year. But this year there are some new guidelines.
There certainly are, and this was one of the most controversial subjects that was discussed. As you said, there were actually nearly 17,000 people who attended from 120 countries, and the American Urologic Association released their new guidance on the early detection of prostate cancer, and they were essentially saying that the PSA is most useful for patients who are between the ages of 55 to 69, and they said that the highest quality evidence for benefit in terms of lower prostate cancer mortality was found in men aged 55 to 69 who were screened at 2 to 4 year intervals, and that the evidence demonstrated that one man per 1,000 screened will be averted from getting a prostate cancer mortality over a decade. So the huge controversy here was, well, what does that mean for men under the age of 55 or over the age of 69? And in fact, one gentleman who stood up is a urologist from the VA out in California, and he was very concerned about patients who fell outside that age category as to whether PSAs would actually be paid for. I was amazed at how much emotion came out about the controversies of prostate cancer screening, and huge concern that we may be turning back the clock, in that if we're not screening these men who are younger than 55 and over 69, will we see what we saw years ago, where men who are not screened present with more advanced disease as a result? So very, very, very
it's very worrisome, because, you know, you and I both see many men who have been diagnosed in their early 40s, early 50s, and there's no doubt. I mean, but the AUA is saying that yes, that those patients, there are men out there that can develop prostate cancer in their early 40s and 50s, but it's not that common. And what, we should just forget about those men? I mean, is this something, like you said, where it's going to come down to the insurance carriers and the Affordable Care Act, where we're not going to be paying and patients are going to have to pay out of their own pocket?
Well, there was certainly concern in the audience that the AUA was following more of a pattern like the United States Preventative Task Force. The task force said that they recommended against screening in all age groups, whereas what the AUA are saying is that they're recommending against screening in under 55s or over 69, but they did have this caveat that individuals should discuss the pros and cons of screening with their doctors, but obviously there's huge concern about this.
And again, this is not for the male that has some symptoms, right? I mean, because this is screening for men that have no symptoms, but the men that come to urologists, most of them are coming because they have like some urinary symptoms, maybe some blood in the urine. I don't think there's any controversy there.
Well, in the AUA guideline leaflet that they gave out to all participants in the conference, they specifically say that the guideline does not apply to symptomatic men or those at high risk for disease, and that these men are encouraged to discuss their individual case with their doctor. Also, the AUA are suggesting that they're providing some supplemental material that urologists can discuss and share with primary care providers. So I think, again, there's going to be ongoing confusion about whether or not we use PSA. One thing that did come out of all the discussions, and also in other sessions, that we know that the PSA test is not perfect, and there are increasing numbers of newer markers that are being looked as a panel. And I've seen, even since the AUA, that this has been covered in the media rather extensively. And in fact, on Thursday and Friday, I had a number of patients who came in asking about this new media coverage about panel markers for prostate cancer. Yeah,
and well, if you have a question about this or you want to voice your opinion, please give us a call at 1-800-848-9222. That's 1-800-848-9222. We are here live on this wonderful Mother's Day. Again, we want to wish all our mothers happy Mother's Day. Just to add on that, Philippa, there was a couple of companies that I went to discuss their new markers for prostate cancer, where they're doing genetic panels. Genomics has become quite a big interest in urology now, where we can look at the DNA of in your biopsy. So if you've had a biopsy and you say, well, you're a low-risk prostate cancer patient, maybe I should just watch it and not do anything. There are a few companies that have come up now to come up with a panel, 4 panels of these DNA markers, where they can give you a new score on your biopsy and tell you whether or not you have the aggressive prostate cancer or not. And I think that was one of the more exciting things in the AUA this year.
That's right. I mean, there's still huge controversy as well about how we manage low-grade, low-risk prostate cancer, the Gleason 6s. And there was an excellent debate between Peter Carroll from UCF and Ash Tiwari debating the pros and cons of managing low-grade prostate cancer. And interesting, one thing that really stood out for me was that it seems more and more clear that if you're a Gleason 7, even if you're a good 7, a 3+4, there was increasing evidence that these are not the patients that we should be managing with active surveillance. I also thought it was interesting that there seems to be significant advances in the software of targeted biopsy machines. I saw some new stuff in the exhibition hall for that, and one of the funniest things was a new device that's out for erectile dysfunction that's called Medispec, and this therapy is an electrical shockwave therapy.
Yeah, I saw that.
Did you see that?
I saw that. You know, electrical shockwave therapy has been used in the past for the Peyronie's, for the plaques in the penis, but this company was trying to say that you go there and you get like shockwave, almost like you get a shockwave for a kidney stone, right?
But a much lower level.
A lower level, and it stimulates blood flow to the penis,
sure,
right?
Well, it's not yet approved in the United States.
Thank God.
But
I don't think that's going to go over well.
I don't know, because the therapy has been included in the European Association of Urology 2013 guidelines on male erectile dysfunction, and it's quite an interesting looking device.
Yeah, it was a little scary to me. I mean, I walked over there and I said, "What are you guys doing?" And they have a model of a guy and this erect penis, and they're directing shockwaves to the penis. And I said, I don't think that's going to take off here.
Well,
in this
you'd
country.
be surprised. I mean, there was a few people who were having a trial run of it in the back of the exhibition hall and seemed to have a smile on their face. So.
The other area that was of interest this year, I thought, and something that we've talked about here on Katz's Corner, is the testosterone issue. You know, can you give testosterone to patients with prostate cancer? And there were a number of papers that showed that men that are either on watchful waiting or have had radiation therapy or surgery in the past can have replacement, the TRT, testosterone replacement therapy. There are a number of ways of doing that now, whether it be injections, not electrodes, but like something on the scalp that you can put on, or as well as on your skin, the androgel. And it can raise your testosterone in those men that have low T levels, and does not appear to affect PSA or cancer recurrence rates.
Also, a couple of things that I thought were interesting. There was a paper that was presented looking at obesity and long-term survivals after radical prostatectomy surgery for prostate cancer, and this was presented by a group in Baltimore, and they showed very nicely that obesity is an independent predictor of biochemical recurrence in those that have had radical prostatectomy. We've known this for some time.
Yeah, they've shown that before, right?
It's not new, but again, it's nice to see these kind of papers, because many urologists are not counselling patients about the risk of recurrence and obesity. The other thing that I thought was interesting was that in the Los Angeles Times earlier this week, it was published about disrupted sleep being linked to a higher risk of prostate cancer, and this was published in the Journal of Cancer Epidemiology, and they looked at Icelandic men and disrupted sleep. So,
well, that may be distress too.
It may be.
I don't. So what was how does a disrupted sleep cause prostate cancer?
Well, they were debating in this paper about the effect of melatonin, and also that disrupted sleep has also been linked to breast cancer and endometrial cancer in women, and that the hormone melatonin that controls sleep-wake cycles may have some relevance in tumour suppression. Also, what I thought was interesting was a paper called It's the Weekend that looked at mortality in men with prostate cancer who went to the emergency room at the weekend versus the weekday. So if you have prostate cancer, stay away from the emergency room on Saturday and Sunday, because...
And especially during July when the new residents start and the new interns. That's always been associated with higher infection rates. And
Is that why I'm on call in July?
Yes, that's why you're on call, to make sure that everything is running well. We'll take some phone calls now at 1-800-848-9222. Let's go to Rich in Edison, New Jersey. He's been waiting. Good morning, Rich. How are you?
Hi, Doc. Happy Mother's Day to you and Dr. Tian.
Thank you. We'll pass it on to our mothers. Go ahead. How are you today?
Okay, I got a question. I had called you about a month ago, and I had a biopsy done on my prostate on March 22nd, and I picked up an infection, a urine infection, which I still have. I've been on different medications, dioxyglycine, Zipro, everything.
And you have the infection in the urine now, and it's but you're not. You don't have still fevers or anything, do you?
No fever or anything like that here. Now, they just put me on microbid, which is making me so sick. I took it yesterday. I got so sick, I don't even know whether I can force it in me today.
Macrobid, yeah. Well, make sure that you take also some, some things for your stomach as well, right, Philippa? I mean, some probiotics would be helpful. When you've been on antibiotics for so long, you're going to disturb your whole GI tract and wind up with some diarrhea and things. The problem is, Rich, is that, you may not have been properly treated beforehand. You may have had this infection pre-existing prior to the biopsy. It may not have been the biopsy that have caused it. So,
oh, really?
Well, it's possible. I mean, if they didn't check you properly beforehand,
right.
And then the question is, why are you getting this infection still? If you probably should see somebody from infectious disease. You may want to make sure that you're emptying your bladder well. People that have this persistent infection, especially men. How old are you?
70.
Yeah, well, if you're 70, maybe you're not emptying your bladder well. Maybe your prostate swelled up, and you're going to continue to have this infection if you don't empty your bladder. So that would be something I would want to check. And if you're still having these persistent infections, definitely get on the probiotics. And I would see an infectious disease specialist. Philippa, what do you think?
I think that if he's had ongoing symptoms of infection despite multiple courses of antibiotics, there may be a role for an ultrasound of the prostate, a transrectal ultrasound. Make sure there's no
abscess. That's a good point. Although he probably
I had the ultrasound done about a week or so after the biopsy, and he said there's no cyst or anything like that.
Yeah, but the thing is, with Philippa's point, an abscess, if you have it, I mean, you might not, but if you did, it wouldn't occur a week after. You wouldn't see it a week after.
Oh.
Okay. You might have some collection there, maybe even a CAT scan of the pelvis at this point, Philippa? That would be probably something to consider, Rich. I would
take Avodart.
No, the Avodart's not going to affect your infection, though. I mean, if you're still having this infection and persistent bugs in your urine, then you may want to make sure you don't have a collection there. I think a good thorough exam, maybe another ultrasound, or maybe even something like a pelvic CAT scan would be reasonable, and also a consultation with an infectious disease expert. Yeah, I mean, urologists, he's going to throw different antibiotics at you, but it's not working, and you may have one of these, resistant types of bugs, which we do see these days because we've given patients so many antibiotics. So I would get in to see an ID person and maybe a pelvic CT. Okay, Rich, let us know.
Okay.
Call us back.
Thank you very much.
All right. I feel well. Radon, good morning in Lakewood, New Jersey. How are you?
Hi, how are you?
Okay, good morning.
I was diagnosed with a high PSA count. I went from about a year and a half ago, I had 3.9, jumped to 22 point something. Then I had tested again not too much longer. I went down to 20. Then the doctor did a rectal examination, determined that I might have enlargement back there. He put me on Cipro, and I stopped eating certain things and drinking water and all that. And I came back 2 weeks later, and my PSA count went up to 28.
All right, and did you have a biopsy?
No, I haven't had a biopsy yet.
You need a biopsy, my friend. I mean, this is do you don't have any symptoms at all?
The only symptoms that I notice is that I'm urinating a little bit more frequently, and the flow, sometimes it doesn't come out in a stream as, easily, as the way it should, I think.
Yeah, well, I don't see why at this point you wouldn't have a biopsy. Even though you have a very large prostate, I don't know what the size is. I mean, a PSA of 28 is somewhat concerning.
They told me that the prostate went down, but they still felt some hardness on the right side.
Yeah, you need
the prostate.
Yeah, I think you need a biopsy. Philippa, what do you think?
I mean, it is possible to have an elevated PSA as high as yours from a urine infection. So hopefully your doctor has done a urine culture to exclude that.
Yeah, they had thought that possibly it was a urine infection, that maybe an old urine infection possibly.
Sure.
But
well, I would definitely agree with Dr. Katz that you need to do a biopsy. More and more we're doing imaging of the prostate before a biopsy, so there may be a role in doing an MRI scan first and then to proceed to a biopsy. But this needs follow-up sooner rather than later, Radon. So I'd urge you to go back to your urologist and get some further information. I mean, it's excellent that you had the PSA repeated, because sometimes people come in with a one-off and we don't treat on a one-off, but, you've had 3 elevated PSAs, so if urine infection is excluded, then you definitely need further workup to find out why this is.
Yeah, okay, thanks for your phone call, Radon. You should get back to us and let us know. I agree, Philippa, with people getting more and more MRIs prior to the biopsy, and I think... the data from the AUA this year did conclude and did show that the multiparametric 3.0 Tesla MRIs can really pick up these lesions and help direct urologists to where the biopsies should be done. The question, of course, is going to be who's going to pay for it all. Again, with the Affordable Care Act coming down, are we going to insurance carriers? I'm on the phone a lot. I don't know if you are as well. Getting these things pre-certified. I have to do a peer-to-peer. I hate that. I really do. one of the secretaries office. You need another peer-to-peer, which means I have to get on the phone with an insurance carrier and another doctor and, tell them why I feel that this patient needs an MRI.
Well, I have to say I've been very lucky with that. And the only patient that I've had to do a peer-to-peer for an MRI request was a gentleman who had a completely normal PSA and a normal rectal exam, but was very, very concerned about having prostate cancer because he had a family history. I had to fight to get the MRI, and the MRI did come back suspicious, and his subsequent biopsy was positive. So we have to fight for the patient.
We do have to fight it, and it's annoying, and it disrupts our day, but it's part of our job now. It's part of what we have to do.
I mean, the other thing with MRI, we used to be so focused on making sure that the patients were imaged on what's called a 3T machine, which is the strength of the magnet. But more and more, it's not just about the strength of the magnet. It's about the software that that the experts have to look at blood flow in the prostate and look at these lesions, and also who's reporting it.
That's key. And that was shown time and time again, that you have to have the experience. And you can't just go to an MRI unit where they're doing, shoulders and knees. You need to go to a centers of excellence. And we use one here in Manhattan, and we also use our center at Winthrop, which I must say is really excellent. And I mean, obviously, I'm biased. I work there, but I'll tell you, I think that the guys at Winthrop do a fantastic job with reading those MRIs. They've been right on. Let's go to Frank in Orangeburg, town near where I grew up in Rockland County. Good morning, Frank. How are you?
Hi, Doctor. How are you?
Okay. What are you on? You sound very energetic.
Well, I'm 84.
God bless you. Wow.
Yeah,
you sound like you're 17. Go ahead.
Well, I feel like I'm 17, except certain times I don't. But I exercise pretty regularly, and I've been conditioned pretty good. But my PSA is in pretty good shape. It's 1.9.
Okay, then you can hang up the phone, Frank, because at 84 years old with a PSA 1.9, I mean, leave your prostate alone.
No, I know, but they found a growth on the left-hand side. And when I asked the doctor, can I get a free PSA test, he said, you don't need it. He says, it's watch and go, As a matter of fact, my PSA jumped to 3.8 because I figured out I had taken a steroid to take care of a stomach ailment. And when I told the doctor that, he says, maybe. I said, not maybe. I know about steroids. I don't take them, but I said they're a growth factor. So after
Frank,
a couple of them...
I think your prostate is fine. A 1.8. What do you mean you have a growth in your prostate?
Well, they did the finger thing, the digital, and they said that you have a lump on the left-hand side, a growth, whatever it is. It's not something that's easy. They just
you know what, Frank? Have them do a PCA3 test. That's what I would do. I would look for reasons not to biopsy you at 84 years old.
No, I wouldn't do it either.
Do a PCA3. That's a urine test. It's non-invasive, and that's.
I think he does that. I do give him the urine.
No, but he probably is looking for just an infection. The PCA3 gene test, which we do quite a bit in our practice, and I found that to be very helpful, especially if the test is very high. Frank, that's what I would do. I don't think I would do anything more than that.
Thanks, Doc. Thank you so much.
Okay. We have another phone call. It's 7:25, so we have just a few minutes left. And if you are listening, I just want to remind everyone, obviously, men's health is a major issue. In fact, I went to the Men's Health Society. Did you go to that, Philip? I don't know if I saw you there. No,
I was in my own session. Remember?
I do remember. You had your own. The British Society was at that day, yes, and you were presenting. But there's a new men's health initiative going on, and a lot of this is going to be discussed at our men's health seminar on June 15th. It's very easy to register. I would encourage you to do so because it is filling up rather quickly. It's menshealthseminar.com. menshealthseminar.com. We would love to see you there June 15th at the beautiful Garden City Hotel. We'll take another phone call. George from Manhattan. Good morning, George. I know you've been waiting. How are you?
Yes, hi, Doctor. Hi. I have I guess it's a dilemma. I have a huge prostate. They say it's benign, huge prostate, and my PSA is been around 4 and change. Now it's 5 and change. But the thing is, I've been taking a saw palmetto type supplement for years and years and years, and now my breasts are growing. So I took hormone tests, and find out my estrogen is way high and the testosterone is low. So now I'm told I can't take saw palmetto, I can't take Pygeum africanum, I can't take flax seeds,
Okay. Forget about what you can't take, George, because we don't have a whole hour here. But what I don't understand, why is your testosterone so low? If your testosterone is very low and your estrogen is high, then that may be the reason why you're starting to see some growth in your breasts. And you may want to be, you probably would be a candidate for testosterone replacement therapy, because your ratio of testosterone to estrogen has been disturbed for some reason. And I probably would do a prolactin blood test. I don't know if they've done that on you.
Let me write that down, please.
Yeah, prolactin blood test.
Prolactin.
Yeah, blood test. And maybe seek the advice of an endocrinologist. But if those tests are negative and your T level, your testosterone is way too low, your estrogen is up, well, I mean, Philippa, that could be a reason. What do you think?
Well, I mean, the saw palmetto does have some estrogenic activity and can result...
Weak, but it could.
It's weak, but, first thing I would do is stop that and see if it makes a difference.
Yeah.
And then,
I have done that. Excuse me. I have done that. Now my question is, what can I take instead to keep the prostate from getting larger?
Well, you probably, if you have a huge prostate and it is affecting your urinating, you probably should go to the pharmaceutical. You probably should take something like Avodart. Although Avodart can also have some weak estrogenic effect, and some of the patients can get breast enlargement with that.
And also, I mean, size is not everything. So just because you have a huge prostate, it depends on symptoms. If you're emptying your bladder and you're not having symptoms, then it doesn't necessarily need treatment.
I wake up every 2 hours. And I don't think I empty the bladder.
You know what, George? We can't give you a full consult here. You're in Manhattan. Why don't you come see Dr. Philippa Cheetham or myself here? We have an office here in Manhattan on Park Avenue,
Which is where?
It's on Park Avenue and 81st Street.
What is it called?
It's called Winthrop Urology.
Winthrop.
Well, but we also have an office here in Manhattan. And we'll
give you the number, George. It's 516-535-1900.
Say it again.
516-535-1900. And there's the music, George. Hope you got the number.
All right, Philippa. Well, that was very great. I mean, you were terrific, Philippa, and latest and greatest in the AUA. And next year it'll be in Orlando, so we'll go to that, and we'll have a greater Winthrop presence there and tell you more. Well, tune in every week, everyone, on Sunday mornings. Don't forget about our seminar. It's menshealthseminar.com. Have a wonderful day, and happy Mother's Day. Love you, Mom. Bye now.